Hi everyone, it's your friend Doris Thecoder back with another video, and in today's video we are going to talk about key coding considerations for anesthesia reporting, proper anesthesia reporting. All right, so with everything, I want to make things easier to learn. If you are new to my channel, welcome, and if you're a returner, I thank you, welcome back. So today we're going to talk about P.A.S.T.A. Okay, so P.A.S.T.A is this. I'm not going to cover every single key consideration for anesthesia because who wants a video that long? But I am going to give you, I would say, my top 5. So the top 5 considerations you can remember by remembering pasta, linguine, fettuccine, spaghetti, penne, rigatoni. I like pasta, so this connects with me on a personal level. All right, so pasta is spelled just like all of those delicious ones are spelled. P-A.S.T.A. Your P is for your position, your A is for your approach, your S is for the site, your T is for the type of procedure, and your A is for age. So starting at the top with your first P, position. You see this a few times throughout the ASA codes, right? Now, whether you're using your crosswalk manual or your CPT or whatever other source you're following, you will see position relevant in a few codes. For example, when procedures are being done intracranially or on the neck, you have options for procedures in the sitting position. That's actually a surgical approach that some providers will do. And what you have to understand in the concept of anesthesia coding is sometimes our surgical codes are very granular, but our anesthesia codes are not. And other times our anesthesia codes present more granularity than the surgical code does. So it's important, so I say for proper anesthesia reporting, you really got to look at both those pieces of information as well as your book so you can land properly where you're supposed to. So in CPT code 00218 as well as 00604, we see the sitting position come up and be relevant. In CPT code 01991 and 992, we see the prone position come up in 92 and positions of other than prone that shows up in 01991 when we're doing therapeutic nerve blocks. Right? If you are dealing with a paper record, and some sites are still on paper records just because, like, politically, sometimes you don't have the God, my neck just got wrinkled. Sometimes you don't have the benefit of kind of modifying the anesthesia record electronically. So providers use their paper records for outages or other things like that. Or you might just be on paper. Providers will sometimes draw the patient positions. They could draw it like little stick figures you see on the bottom of your record. They could also abbreviate it, SUP, for supine, PRO, pro for prone, or just a P. Or if it's an electronic record, it could be very explicitly stated for you where there's just no guess or consideration. Although it doesn't help you with your ASA code selection, the position can also be a clue to you on when surgery starts. So if you're tracking some of those measures based on surgical start time, like we used to do antibiotics and things like that, it would be important to see when the position changes, because most patients roll into the OR laying on their back, but there's so many different approaches to procedures that they may not have the surgical procedure on their back, particularly if their procedure is on their back, right? We're not going to lay you on your back, but we'll maybe lay you on your back to roll you into the OR to get you sedated. So that's the first letter in P.A.S.T.A, position. The second letter is approach. Now, the tricky part, and quite interesting, sometimes your position can also allude to your approach. Because there's so many practices that are coding anesthesia without operative reports, that blows my mind. If you guys see this video, if you could just let me know, like, are you coding with operative reports? Anytime you get an opportunity to code with operative reports, it's a really good source to help providers document properly because they see how much is missing from their documentation compared to the operative report. I'm going to digress on that point for a moment. But the approach is going to be very important, because if I see where I say the position correlates to the approach sometimes, if I see the patient lying on their back, as I said, I know and they're doing a spine procedure, I know the back is not the approach that they're going on. But again, they always roll in on their back. So you want to see if the patient is repositioned. You might see Trendelenburg, lithotomy, some of those different types. And if you're not familiar with what those approaches look like, just Google them, and you'll see what they look like in real time. So right before surgery starts, they'll change the position of the patient. That's going to let you know what the approach could be. And because many sites are coding anesthesia without having operative reports, you don't know what, you don't get kind of the full picture. You have to use everything within your record. There are oftentimes hidden clues within your anesthesia record that allude to the proper approach of a procedure. Like I said, if the patient's laying on their back and it's a spine procedure, we know it's likely an anterior approach because we're laying on our surgical site. If I'm doing a vascular procedure or a major blood vessel procedure and I see that there's aortic cross clamping, I know that's an open approach because they can't clamp the aorta from inside the aorta. They can occlude the aorta, but I don't even know them to do that. They can clamp it, however, if they're doing a really bloody procedure, and that's going to lead to an open approach to the procedure. All approaches is how did you get where you're going, right? So when you got to the site, what route did you take to do that? You might see terms like open, closed, endoscopic, percutaneous, thoracoscopic, anterior, posterior, sometimes in your code descriptor. So all of those can be clues to your approach. You look at things like blood loss, that could be another hidden clue in your record, right? And that's not to say you could have a patient who's, just not a bleeder, especially a patient could be on blood thinner. It could just be, they could be an easy bleeder. But for the most part, if you see like massive major blood loss outside of some kind of complication, or a larger amount of blood loss, that might, I say might, be indicative of more of an open procedure as opposed to a minimally invasive approach. Minimally invasive procedures are typically less bloody than open procedures, which is why one of the reasons why they do them, even though they can be a little more technically challenging. Examples here: valve procedures. Chest can be cut open to access the heart valves. They can also follow like blood would flow right into the heart and do it transcatheter. Well, that's going to make a difference between you having a 01926 and a 00561 or a 00562 like procedure, right? Because the approach. A hysterectomy is a really great example as well. There's many different approaches to hysterectomies. They can go open, they can go laparoscopically, they can do vaginal hysterectomy. So the uterus can be delivered just like our babies would, right? And that's going to change between your 00944 versus your 840. That approach showing up again. You'll also see this all throughout CPT quite candidly with biopsy procedures, endoscopic procedures, because that's just another minimally invasive approach. The S in your P.A.S.T.A is site, as I said. So once we position the patient, decide how we're going to get there, where exactly is there? Where are we going? What's our target? What's the structure that's being worked on? So is it an artery? Is it the stomach? Is it the esophagus, right? And get specific. The esophagus, for example, you have a part of the esophagus that's in the neck and you have a part of the esophagus that's in the chest. So what's the part? I ask my docs, what's the part? I shouldn't need the surgeon's report to know exactly where you went, right? Because it matters to you. Money matters. One word changed my ASA. So the specific site is going to be important. So the lower esophageal sphincter would be a good term for the providers to use. Don't just say artery. We've got arteries from head to toe, right? The artery where? Is it the artery, the pulmonary artery? Is it the artery of the arm, the leg, the pelvis? Where's our artery? So in a specific to knowing the organ or structure, having the specific location is going to be important too. This is going to be really important for you also if you find yourself coding unlisted procedures, because the ASA crosswalk is great. It is of no value when you have an unlisted procedure because the unlisted CPT code could represent a number of procedures that are not yet classified. I warn you, also use your Pinocchio codes, as I call them, category 3 codes, those temporary codes, because sometimes they actually route you, but you may justifiably be using a code that ends in 99 from your CPT section, right? So what do you do then? You factor your organ, you factor your structure, and that'll at least get you kind of in the area where you should be when you're reporting. Then we deal with that T. So the type of procedure. And you think, oh, why? You just said the approach. What do you mean the type of procedure? Well, there are different types of procedures for which anesthesia could be performed. There are diagnostic procedures and there are surgical procedures. You might hear it documented or verbed as diagnostic or therapeutic, or diagnostic or interventional procedures, right? So they can do an angiogram, and an angiogram is a diagnostic procedure. For those providers that do anesthesia and pain, you could do a discography or a myelogram, right? Those are diagnostic procedures. Or the provider could do a percutaneous vertebroplasty or kyphoplasty or discectomy, right? That is a interventional or therapeutic procedure. So am I going there to find out what's going on, or am I going there to fix something? A patient could have abdominal pain, right? And after all the workup and whatever, we still don't know what the cause of the abdominal pain. So the provider might do a laparotomy, go in and we don't find anything. What we've done is a diagnostic procedure. If we go in and we see a drain, or we see a cyst, or we see an abscess and we drain it, we've now treated or targeted something. So you'll see the interventional or surgical. You'll see this in respiratory, digestive, musculoskeletal, for example, just really all throughout your CPT. And the final A is age. Now, you do have a qualifying circumstance code. I'm not going to try to remember it, but it's a 99 code for patients of extreme age. Many times in anesthesia, some payers pay it. Not every payer does. So if a payer only pays you the BT part of the BTM formula, meaning they pay you base and time, but they don't pay you for modifying factors, they don't pay you for how old the patient is or how sick the patient is, you do not make any more money by using the qualifying circumstance code, because it's not reimbursable by that payer. They've got a policy on it. But there are some codes, and you want to be aware of these, because you're either paid for your ASA or you aren't. So they have a few codes relative to patients who are under the age of 1, so they haven't reached their first birthday yet, under the age of 1, that factored the extreme age. We don't have a code that factors a patient that's on the opposite spectrum of extreme age, that's over the age of 70, but we have a few that actually factor the patient being under the age of 1. 00326, these are your larynx and trachea procedures for patients under the age of 1. Now, I spoke of those qualifying circumstances. In the event that one of these codes is appropriate, the qualifying circumstance is out. You don't need it. It's already factored that and valued that in the CPT code. You have to be aware of your patient age, though. So if this is manual for you, you can make that error. If you can write rules in your systems to say, hey, if patient age is this and this code is used, slap it, tell it no, right? So you can get some warnings in your system and not get a denial or get some issue from a reimbursement perspective. We see it in 00326. We see it in 00561, for example, for cardiac procedures. We also see it in our hernia procedures. So we have 00834 and 836 for those patients on the lower end of the spectrum of extreme age, that is younger than 1 year old. If you are coding pediatric, all right, so if your hospital just does everything, like we pay special attention to this because we're, one of my clients is a pediatric hospital, right? I tell my coders, we got to look at the pre-op eval. We've got to look at the history, because beyond factoring that 834 just says the patient is under the age of 1, I want to know whether they're preterm, right? So what age are they actually, right? And if they are preterm and it's being operated on in that window that's specified by the ASA code very clearly, then I want to factor them just being more than just extreme age. They're very little. I had a case, for example, the child was born at 28 weeks. Right? And the hernia was repaired, I think, maybe 6 weeks after the child was born. So they were still within the postnatal age that they were talking about. And the code was built to factor the risk of operating on not just a child under the age of 1, but a very small child who hadn't been able to fully develop to full term in utero. Okay, so I am your friend Doris Thecoder. Remember P.A.S.T.A to properly code anesthesia. Those are my 5 tips. It's not the only 5, but I don't want to keep you on here all day. So P for position, A for approach, S for site, T for type of procedure, and A for age. So thanks for stopping by, and I'll see you in the next video. Give me a like, share, subscribe. If you know anybody that finds it helpful, you know what I feel, share it. Let them learn, and we'll do that together. Talk to you soon, and I'll see you in the next video.